That's the first one. Okay, the question, describe the abnormality and the morphological diagnosis. Here we have two abnormalities. The first, and there is also the probe that underlying the lesion, is in the leaflet of the aortic valve, and there is an erosion, in this case, very clearly. And of course, the cavity of the left ventricle. And so the morphological diagnosis is ulcerative, erosive aortic endocarditis, and secondary congestive cardiomyopathy, secondary congestive cardiomyopathy of the left ventricle. What do you think? Elizabeth, is there Elizabeth?
There is, hi.
Okay, which is your answer?
I think actually I got it quite wrong, to be fair. But how you can call it as congestive cardiomyopathy?
For me, yes, why not? Dilated congestive, secondary, because the lesion.
No, I understand.
Yeah, congestive dilatative is the same.
Oh, okay, that makes sense. Okay, thank you.
And did you recognize the aortic valve lesion?
Yes, I just called it completely different, but yeah.
Perfect. And about the describe again, the keywords are, of course, the ulcerative lesion and I don't know. Do you want to read your description?
Be fair,
If you
I do
want,
about it. I can. I didn't write much there, to be fair. I just written that it's the aortic lesion, but I didn't write it's the ulcerative or erosive. So I didn't recognize it, and I only recognize the dilation of left ventricle.
Okay, perfect. And Sid, what about you for this picture?
Yeah, so I identified the chamber dilation, but I got a little bit confused as to what the probe was pointing at. So I thought it might be a.
So if you want to open the camera, please.
Oh, sure. Where's that? Is that working?
Yeah.
Oh, sorry, I have two screens, so I might not be looking at the screen. Yeah, so I got confused by the probe. I thought it was pointing to a narrowing stenotic lesion, so I've written down stenosis with LV dilation. It doesn't make much sense.
Yeah, me too.
So is it not clear the erosion in the leaflet?
It is now, yes.
I was, for example, I was wondering. I wrote that it's erosive changes in the aortic valve, but I was asking myself if there is some supravalvular ridge, but probably it's just oblique view, and that's like just normal annulus.
The annulus could be also dilated, Ursula, because there is a dilatation of the ventricle.
Okay.
So Massimiliano.
Okay, I'm sorry. Can I follow the list of the colleague? For example, Maria. What do you think, Maria, about this picture? Everything is clear?
I have problem with my micro. I don't know if you can hear me.
I don't listen you.
I have problem with the micro.
Okay. Okay.
I was wondering if there are a lesion in the valve.
I think Maria just said, wonder there was a lesion on the valve.
Okay.
Can you hear me, Massimiliano?
Sure.
Oh, okay. So you can hear, because I don't know whether you can hear me. But basically, the lesion that I can see were just below the leaflet and below the probe. So between the leaflet and the probe, I could see some lesions there. But is that what you mean?
Sure. So the probe is inside the erosion.
Okay, so the whole thing is erosive then.
Sure. And what about Fabio, what about the ventricle? Did you recognize the dilated cardiomyopathy?
Well, to be honest, I thought maybe, let me see, I thought there was possibly mild hypertrophy as well, but maybe not looking at it now.
Okay.
I don't know.
Eccentric hypertrophy.
Well, I have to be completely honest. I thought it was concentric hypertrophy, but now looking at it, it looks
concentric. No, the discussion could be about dilatation and eccentric hypertrophy, but of course not about the concentric hypertrophy. Of course.
So basically, here there is like aortic endocarditis with aortic insufficiency that is causing the kind of eccentric dilation. Is that right?
Yeah. That's it. And for describe, the keywords could be the erosion on the flap, and also the shape and the volume of the left ventricle. So increase of the cavity. I agree. We may to discuss about real dilatation and so real congestive cardiomyopathy or eccentric hypertrophy, but also in the primary DCM, sometimes we see the eccentric hypertrophy, but we spoke about dilated cardiomyopathy. Do you understand me, Fabio?
Yeah, that's perfect. Thank you.
Okay, and what about Gitte? Gitte?
Yes, hello.
Do you, please open the camera so can I see your face?
Hello.
Hello, perfect. So what about your experience for this picture?
Well, I had a bit of the same problem, I think. I also saw kind of a lesion on the aortic cusps, but I didn't write it down as endocarditis, to be honest.
Did you recognize the ulcerative endocarditis? Is it correct? I understand well. Did you recognize the ulcerative endocarditis?
I didn't recognize it as endocarditis, but yeah, I saw that something was wrong on the valve in the aorta.
Okay, and I also now do you see that there is a solution in the flap? Okay, and what about the cavity of the left ventricle? What did you see?
I wrote down that I thought the thickness is normal and the volume is normal, but I don't really see how you describe it as right.
Okay. What about Claudia?
Well, in this image, I could see the enlargement of the left ventricle, but I also had problems to see the endocarditis. Oh, what's the story with this flap where the probe was? But now I can see it after you explained.
But of course,
initially I had my problem.
No problem. That's if you make every day one thing, it's easy. If you make the same things every month, is more difficult. Don't worry. But did you see the probe?
Yes.
So that's. I don't think that for your examination there will be a probe. And so maybe you have to take more.
Let's hope so.
I don't know. I don't think so.
Massimiliano, one thing, I actually wrote dilated left ventricular outflow tract because it looks like the aorta is quite large.
Sure, I agree. Of course, because there is an enlargement of all the left ventricle.
Yeah.
Yeah.
Massimiliano, can I ask you a question?
Sure, Mattia.
Would we be able to? Would we be able to call this? Then you said you should call it endocarditis even without a probe. Is that right?
I think so. That is possible because
Okay.
there is an erosion. But I put also the probe take a picture just for help for the interpretation. But I think it's possible.
Okay. I couldn't see probably even with the probe, so amazing.
And for you, Mattia, what about the cavity of the left ventricle?
I didn't write anything about the size. I wrote LV as some moderator bands. I don't know, maybe, but I don't know. There's one over there.
Now is more clear the case. The situation is more
Yes.
clear.
Honestly, I thought it was an aortic stenosis, but I didn't really know where it was the probe, to be honest.
Sure. Okay, what about Joao?
Can you hear me, Massimiliano?
Sure.
Okay. So I wrote that there was a mild. I wrote mild left ventricle dilation. I wrote as well that the valve, the aortic valve, look. I didn't say ulcerative. I thought it was a bit eroded. However, I also was wondering why the probe was there, and in fact, the probe made me to think that there was a ridge causing a degree of stenosis as well. So, in fact, I wrote down that could be a fixed aortic stenosis with erosive endocarditis. So I thought the probe was to show that there was an obstruction and that the orifice was narrow. So I didn't realize that the probe was to show that there was a proper ulcer in the aortic valve leaflet.
Okay, but now it's clear?
Now it makes sense. Now it makes sense after your explanation.
Okay, and what about Marine? Which is your experience, Marine?
For me, I was once too. I was thinking of an aortic stenosis with dilatation of aorta, and but I don't see the erosive lesion of the aortic valve.
Okay, now is it clear?
Yes, it's most clear. Thank you.
Okay, but take care because usually, not always, of course, but if we show aortic stenosis, most commonly there is a concentric hypertrophy.
Yes,
makes sense. Of course, in very late stage, there is also afterload mismatch, but in very chronic situation. Okay.
Yes.
And what about the cavity of the left ventricle? Is it clear?
Yes, it is clear. I was thinking of normal cavity, but
yeah, of course, it's not so severe, but I think it's significant. Also, the gross examination. Okay, thank you, Marine. Fabio, for you, everything is clear? Yeah, I think so. Fabio?
That's perfect. Thanks. Yeah.
Okay, Ursula, what about you?
As I said before, what I wrote, it was mild ventricular enlargement and erosive changes on the aortic valve, but I thought there is some fixed obstruction as well, this valvular ridge.
Okay. Now is it clear, Ursula?
Yeah, definitely.
Perfect.
Thank you.
Julie?
Hello. I said I thought it was an erosive aortic valve endocarditis with left ventricular volume overload as well. The only additional thing I said was that I wondered if there was some mural involvement of the endocarditis as well, just because I thought maybe there was some involvement of the very basilar aspect of the intermatricular septum, but perhaps that's too much detail, I'm not sure.
Yeah, is it correct that the comment and the reddish part of the cavity in the left ventricle is because postmortem alteration? Okay. What about Jonathan?
Hello, can you hear me?
Oh.
So me, I put necrotic endocarditis, so I didn't said ulcerative, and I thought there was an aneurysm of the sinus or valsalva, so I wasn't sure because there was a probe. So, and I didn't put left ventricle dilation. I just put so as I said, aneurysm of sinus or valsalva and necrotic endocarditis of the right coronary aortic cusp.
Okay.
And I put exophytic lesion, but I wasn't really convinced myself, to be honest.
Okay. Now is it clear, Jonathan? The situation?
Yeah, I think so. But I as I said, I was just confused with the words. I mean, I guess ulcerative or necrotic, is that the same?
So it's the same. It's the same, sure.
Okay.
But usually for this situation, we prefer to use ulcerative.
Okay.
Of course, there is an ulcer because there is the necrosis. Is it correct? But from a formal point of view, it's better if you use in this lesion ulcerative or erosive endocarditis. But the concept is correct.
Okay, thank you.
Okay. Okay, the second, Alessia, thank you. The second slide. That's histology, of course. We have been together also yesterday, this kind of situation with Masson. Elzbieta, is it clear, the situation? What do you think?
Hi, I have to say definitely not because I missed the histology part yesterday because I was working. So I think I see fibrosis, but I can't really tell is it endocardium or epicardium.
Yeah, that's a situation which we see very well, a thickening of the endocardial layer, and that's because fibrosis, and also in the closed myocardium there are multifocal interstitial and in particular replasment fibrosis.
Thank you.
Because if you look carefully in the myocardium, I think that in the endocardial layer is very clear. In the myocardium, it's very clear the replasment fibrosis, but just around some portion of the tissue there is interstitial fibrosis. So we may to say also in general endomyocardial fibrosis. About the name of the abnormality. And what about the SID? Is it clear for you, Sid, the picture, the concept, the information?
Yes, I think so. I sort of wrote down the fibrosis, and is this what they mean when they talk about myocyte disarray?
No, here there is not a disarray.
There's no disarray. Okay.
No, take care, Sid, but also for everybody, because at histological examination, we appreciate the disarray when the myocardial cells are in longitudinal pattern.
Okay.
If you take care about the picture of disarray, for example, in hypertrophic cardiomyopathy, usually the myocardium are in longitudinal presentation, also because they have to show the branching.
Right. Okay, I understand.
Is it clear, Sid?
Yes, thank you. That's very helpful. But yeah, I can appreciate the fibrosis, both replacement and interstitial.
Okay. Thank you. Maria, what about you? Is it clear? Did you recognize the abnormality? I don't listen to you. Okay, perfect.
It
Thank
has a
you.
problem with the microphone.
Yeah, perfect. I understand. And what about Gita?
Yes, I also know with endomyocardial fibrosis. For me, it was
So did you recognize the endocardial and myocardial fibrosis?
yes.
Good. Everything is clear. Good. Claudia, what about you?
Yeah, this one was clear to me.
Perfect. Thank you. Joao,
I wrote endocardial fibrosis, and I wrote replacement fibrosis. I didn't write interstitial fibrosis. Could we say that this could be a replacement fibrosis as well, or we have to say that would be?
of course, the main myocardial fibrosis is replacement fibrosis. But if you look carefully between the replacement fibrosis, there are some.
It also has interstitial fibrosis as well.
Yeah.
Yeah.
Thank you, Joao.
Yeah.
Say me. Is it clear?
You also asked us to name the abnormality. So I just said endomyocardial fibrosis, most likely restrictive cardiomyopathy.
That's correct. I like it. Okay, they care about morphological diagnosis and the difference with functional or clinical definition.
So the morphological in this case would be endomyocardial fibrosis, right? And the function will be restrictive.
Yeah, I like it.
Yeah.
Thank you, Joao. Mattia, what about you?
So yeah, same. This one I think I was slightly more correct. So I got the fibrosis. My definition was myocardial fibrosis plus subendocardial fibrosis. Then the description I put fibrotic tissue infiltrating areas of poor/no myocardiocyte and the subendocardial thickening.
But did you see also the endocardial layer?
Yeah, so that's what I do called subendocardium. Am I wrong?
Subendocardial is in the myocardium. If you say something is in the subendocardial portion, you exclude the endocardial layer.
Okay, so that would be endocardial and that's it.
Endocardial and myocardial. Of course.
Yeah, no. I mean the layer, the lateral portion of it. That's only endocardium.
Sure.
Okay.
And the white is because there is the cavity.
Yeah. Okay, so I missed. So I called it wrong as subendocardium. I called it subendocardium.
Yeah. Take care about also the wards. Take care, guy, about the wards. And what about Marine?
For me, it was clear fibrosis of the endocardium and myocardium. I note.
Good. And so, name of the abnormality for you was?
I note on endomyocardial fibrosis and in cardiomyopathy, so restrictive cardiomyopathy.
Yeah. Okay.
Yes.
Perfect. Thank you. Fabio, what do you think?
Yeah, no, I got endocardial fibrosis. I was just wondering because I wrote, I don't know how to describe, I know it's an endocardial fibrosis, but to describe, I said distensive fibrotic superficial thick layer of the endocardium. Is that correct? How would you describe the lesion? Because the diagnosis was pretty clear, and I think I'm happy to explain the myocardial part. But the endocardial is enough if we say hi Julie Scott.
Yeah.
Is enough if we said thickened fibrotic endocardium. Is that right?
Yeah. Good question. So for the endocardium could be the keywords diffuse severe thickening by a fibrous tissue or by from here, for example, you don't see the cells. You cannot to say which kind of cells. But because there is the mason, you may to say that's a fibrosis. And so diffuse severe fibrotic thickening, for example, it could be also a possibility.
Okay. Cool.
And for the myocardium could be multifocal replacement of myocardium by the fibrotic tissue, connective tissues. That's enough.
Perfect. Thank you.
Okay. And Ursula, what about you?
I think for me, this is everything clear in this case. It was one of the easiest one. I wrote the endomyocardial fibrosis, severe fibrotic replacement of the myocardium, and endocardial thickening.
Wonderful.
And RCM as the diagnosis.
Thank you. Yeah. Endomyocardial fibrosis, morphological diagnosis, clinical / functional diagnosis, restrictive cardiomyopathy. Okay, thank you, Ursula. Julie?
Yes, I had the same diagnosis as well. I was a bit lazy and just called it restrictive cardiomyopathy. I should have called it endomyocardial RCM, but everything else I got right.
Okay. Now is it clear?
Yes.
Perfect. Jonathan, what about you?
I think it was clear as well. I just, like João, forgotten to put interstitial fibrosis. I just put replacement fibrosis within the myocardium and thickening of the endocardium as well.
Mm-hmm. But for me, replacement fibrosis is enough. Of course.
Okay, well.
And what about the endocardial? Was clear?
Yeah. On the myocardial fibrosis, I saw that the endocardium was thickened with the fibrosis, so no problem with that.
Perfect. Thank you. The next one, Alessia, thank you. Okay. Elzbieta, what about you?
Right, so I think this is the right auricle mass, and this is dorsal cranial view, and I think it's infiltratory.
Okay, it was okay. Okay, sorry. Okay. We are looking, of course, a part of the base of the heart.
It's a cat. Oh.
Yeah, that's a cat, feline. And we are looking in front of us. There is a septum. And more ventrally, there is part of atrioventricular valve. And on the left side, there is an auricle. So, which is the atrium that have the auricle running on the left?
Well, that must be the left auricle.
That's the left atrium and left auricle. Is it clear for everybody the anatomical position? Okay, and what about the auricle? Which is your description?
I say some brown colorish material within it.
Sure. Okay.
There's a cat, it's unlikely to be a mass, so then more likely to be a thrombus, I guess.
Yeah, a mass, okay. But what about the link with the wall?
Yeah, so I thought it was infiltrative, but it was a cat, that's very unlikely.
Infiltration is not, there is not infiltration, but is adherent to the, is adherent. And so, which is your conclusion?
It will be the thrombus.
Thrombus. That's a thrombus. That's a thrombus. That's a thrombus. Is not very, very clear, but maybe with a little speculation, we may to see that there is also dilatation of the atrium and auricle. Okay. Sid, what about you?
Yes, I got this one correct. I didn't dilation of.
Did you recall?
But I identified that it was a thrombus in the left auricular appendage.
Perfect. And so the morphological diagnosis was left atrium thrombosis, for example.
Yeah.
What about Maria?
Yes, I thought thrombus. I wasn't clear it was an infiltration or an adoration, but I thought it was.
So did you recognize the thrombus? Yes. Well, did you?
I had questions about the wall of the atrium, but
Sure. Which is the question?
that I didn't recognize that was an adoration. I thought in an infiltration. So it wasn't clear for me. I thought in the thrombus, but for me wasn't clear.
Maria, sorry, Alessia, write if you want to use the chat. If you want to use the chat.
If you want, I think I heard what she wanted to say. If you want, I can just tell you. Yeah. I think Maria say yes or no if I'm right, but I think she said I recognize the thrombus. I was just wondering if the appendage wall was normal or not. Is that right, Maria?
Yes.
Good. Okay, in this presentation, the wall is normal. This presentation, the wall, there is not nothing too significant. It's not a neoplastic infiltration, for example. Also because if you recognize the thrombus, and or there is inflammation of the wall and also of the endocardial layer, but otherwise it is not so visible an alteration of the wall. Okay, Maria. Git, what about you? Did you recognize the lesion?
Yes, for me, it was clear. I also had a dilation. Thrombus formation in the left atrial appendage. So yeah.
Okay, everything is clear. What about Claudia?
Yeah, at first I thought this was one of the more difficult ones, but I got the same notes on my paper that were described as the findings here. So
I don't listen you very well. Please, could you repeat?
oh, sorry. Yeah, this one is clear.
Okay, perfect. And Joao, what do you think?
I wrote that we were looking at the dorsocaudal view of the left auricular appendage and left atrium. There was material adherent to the left auricular appendage wall, brownish. That would be most likely to be a thrombus. The only thing I would like to ask is if we need to describe the thrombus, can we say? Do we need to say material? Can we say lesion? What would be the best term?
Oh, good question. That's a material mean that is not disorganized. There is not a visible organization. Material is a general concept. And we may to see there is a formation, solid formation, for example, compact, solid, brownish, whitish, because there is some part of it, the cut section, formation in the cavity of the left ventricle, adherent, that's a key word, adherent.
Yeah,
The key words for the thrombus, remember, is have to be adherent to the endocardial or to the endothelial surface.
Okay, so formation. Okay, thank you so much.
Yeah. Mattia, what about you?
Can you hear me? Yes. Yes, I mean, I got that. I do put some differentials as, for example, neoplastic, I have to say. Like I put the first as thrombus, but I would lie if I say that to me looked like a classic thrombus there. I thought that the wall, as Maria was saying, I thought the wall did look a bit weird. I agree there wasn't any infiltration, but I put, what did I put? So I put like there was a thickening of the area below the left atrial appendage wall that was compatible with a thrombus or a neoplastic formation. So I have to say I did put thrombus first, but then I put also neoplasia.
Sure. How many times did you list and there is a neoplasia in the atrium in the cat?
Yeah, I mean, in this case, probably as soon as I read the feline, I will write either HCM or thrombus.
I'd like to see this kind of neoplastic lesion in the cat.
Yeah, no, I agree. Then probably you suggest me to be more realistic. Our cardiology is more boring than we think.
No, not boring. That's interesting point of view. But for your examination, think about the most classic.
Yes, no,
the most classic.
To be honest, one of the reasons why I put the thrombus. But
yeah.
Okay.
And what about Marine?
I saw that it was a thrombus, but to be honest, I think it's hard to recognize the left from the right auricle. Sorry, but I assume it makes more sense in the left atrium, so I note a thrombus in the left atrium, but the difference between us is difficult for me, right to the left.
Okay, now, I will try again. In this picture, the point of view is, of course, dorsal, caudal, and a little on the right, So I see a septum in front of me. Just below, we see a part of the atrioventricular valve and the auricle. But if you remember the anatomy of the auricle, if you remember that is like a half moon, like a C, and if you remember that the left auricle go to the cranial and to the left, and the right go to the cranial to the left again. You understand me?
Yes, I understand. It's not easy, but I understand.
Yeah, I can imagine. Don't worry. And Marine, Fabio.
Yeah, this one was clear.
Everything is clear, Fabio?
Yeah, it was clear. Thank you.
Perfect. What about Ursula?
I have to say this was, I think, the most confounding for me, because I was thinking very long where I am, what I am looking at, and I just wrote that it's most likely thrombus in the left auricle, but only because I saw this is a cat and I couldn't find any other connection with the other structure. But it was guessing for me in this case.
But now is it more clear? Did you recognize?
Yeah.
Okay. Julie, what about you?
Yes, I thought it was a thrombus. I think I thought that there was some abnormality of the wall of the auricle that might have predisposed partly to development of a thrombus, but I didn't think it was anything else differential-wise.
Okay. Jonathan, what about you?
I'm happy with this one.
Are you happy? Everything is clear, Jonathan?
Yeah.
Perfect. So, Alessa, the next one. Thank you very much.
Sorry, just the last very quick thing. So it is rather common. I understand that when you've got thromboembolic disease or thrombotic disease, you can see the thrombus formation on the wall as well, correct?
Yeah.
So that's why it looks kind of thicker. It can be like
Sure.
that, like all around the
shape.
surface.
Yeah, the shape is very important, of course.
Okay.
So we observed this picture also during the workshop. It was an autoptic picture. Elzbieta, did you recognize the lesion? Did you recognize the abnormality?
I only recognize this enlargement of the liver and congestion.
Severely?
I would presume to right-sided heart failure, but I don't see this on this part there. I don't know how I would recognize it.
Did you see the pleural effusion?
Well, I see the fluid. I just don't know. I didn't know this is going to be a post-mortem fluid or this is actual pleural effusion fluid.
Oh, no, it's not possible. This kind of post-mortem fluid. That's a real post. It's not post-mortem. It's a real fluid. And for the color, we made to say that is a transudate, hydrothorax.
Okay.
And so hepatomegaly because there is a severe congestion, hydrothorax, enlargement of, so I like also to say of the cardiac silhouette because the heart is inside the pericardial sac. So, and it's a very young dog because there is the thymus very cranially to the heart. And so the problem is on the right side. It could be, for example, pulmonary stenosis, like in these cases, or also some malformation on the right side. Why not? It could be fallout. What do you think? Well, everybody, it could be fallout.
I think it's possible, but I think I took.
Yeah,
Any
I
comment?
think most dogs we see with a pulmonic stenosis that are already in congestive heart failure often have a severe bicuspid regurgitation as well.
Sure, I agree. I agree. Sid, what about you with this picture?
I saw the abnormalities, the hepatomegaly, the pleural effusion, and I get pulmonic stenosis.
Of course, we don't see the pulmonary stenosis, guy. Is it clear? That's a mental process.
Just the most likely.
Yeah,
just because I think it's most likely. But I suppose, other differentials would be tricuspid dysplasia,
sure.
tetralogy.
Why not?
Yeah.
Sure. Okay, what about Maria? What about Gitte?
For me, it was also actually clear. We discussed it earlier. I wrote actually everything. So the enlargement of the cardiac silhouette, the of the transit in the thorax, so the plurality, in the hepatomegaly as well, and the thymus as well, and then the right side of congestive heart failure because of a congenital disease, and then also differential diagnosis.
Okay, I don't listen you very well, but I understood some words every 10 words. I understood one word. So now is it clear for you?
Yes.
Okay, perfect. Thank you very much, Claudia.
Yeah, I'm happy with this one.
Good. What about Joao?
Yeah, so I got everything, the differentials as well, description. The only thing that I'll be in an exam situation that I'll be a little more concerned is to identification of the timers, to know the age of the patient. So that would be the only thing that I would struggle in an exam situation, is to identify the timers, because that would be the key here for the obviously you are asking for the congenital, so it needs to be a young dog. But if we didn't have information that was a congenital, I probably would miss the thymus in an exam situation. But yeah, so enlarged cardiac silhouette, hydrothorax, rounded liver and enlarged liver, so congestion, right-sided congestive heart failure, and pulmonic stenosis. And yeah.
The question could be also in a different point of view, because the question could be gross abnormality and the most likely cardiac disease.
So yeah, so if the question was like that, my answer would be
a lot of disease you made to put.
Yes, exactly. So I probably would miss the thymus to indicate that this patient was young. I probably start to saying more acquired conditions for the right side, like pulmonary hypertension, tricuspid valve disease, or an acquired left direction. Yeah.
Sure, cardiac or extracardiac disorder, of course.
Yeah.
Take your time, not a lot for the examination, unfortunately, but take time for you for study the picture. You have to observe every particular. Okay. What about Mattia?
Yeah. So this one, I mean, I have to say it was a bit cheating because I was there when we commented it during the sessions, so I knew the answer, I have to say. And that's why I also wrote thymus. I felt very proud of myself, but it wasn't my merit.
It's
I
important.
just remembered from earlier on. So yes, I put large liver, serous. I called it a serous antelope, but I don't know if it's correct. Maybe just serous.
Sorry, you look Robocop. Mattia, I'm sorry.
Young cats.
Mattia, you look Robocop.
Can you hear me?
Yeah, that's better. Okay, what
can
about
also move like it if you want.
What about Marine?
It's really clear for me. I have no question. It's clear for the session and no.
Perfect, thank you. What about Fabio?
Yeah, I'm good with this one. Thank you.
Ursula?
I wrote cardiomegaly, more pronounced on the right side, pleural effusion, hepatomegaly, signs of right-sided congestive heart failure.
Okay, I think it's a good interpretation. Julie?
Yes, I said the same as everybody else. The only additional differential I gave was CTD, although perhaps it's a little bit young. I know they present in heart failure a little bit older, but that was the only extra thing.
Okay. Jonathan?
This is okay for me.
Perfect. Okay,
And
the next
Maria,
one.
for her was for Maria was pulmonic stenosis.
Okay, okay, thank you. Okay, if you want, we may to continue more quickly. For example, do you prefer the next one, Alessia? Thank you.
Yeah.
So it was I think it's a clear situation. Of course, that's a neoplasia, and for the gross finding, also in particular for the color of the nodules, that's a hemangiosarcoma. But the hemangiosarcoma usually is not so huge. It's, in this case, it's very, very big. And there is a severe infiltration also of the cavity of the right atrium, of the right ventricle. Did you see? That's a very huge, incredible hemangiosarcoma. And in case of neoplasia in general, could be correct to say most likely diagnosis, because of course the golden standard for the diagnosis is the histological examination. But I think it's the gross findings are very, very clear for the neoplastic lesion, and of course for endothelial origin, so like the mangiosarcoma. Any comment?
The only one that I was wondering that the dog could be alive with obliteration of the whole right heart.
I agree with you, Ursula. It was incredible. There was also a lot of pulmonary metastasis. I don't know. It's very strange. It's incredible. It's incredible.
Massimiliano, can I ask?
Sure.
Is it possible to identify the origin of the lesion from this picture?
No.
Like it would make sense to be right auricular appendage.
No. Of course, we may, but that's a speculation to say that is from the right auricle, right atrium, because we know. I'm sorry.
Ciao, ci vediamo dopo.
Ciao, amore. Sorry, I have to say my daughter. Ciao, amore.
Ciao.
Ciao, Kika.
Ciao, papà.
I'm sorry. We made to say, but that's a speculation that the origin could be the right auricle, but now it's impossible.
Thank you.
Other question?
Sure. Any other differential
diagnosis for other lesion or other neoplasia?
No, anything, because my differential was very small. It was just neoplasia.
Now is not possible. Non-neoplastic origin of the lesion, because it's not obviously inflammation. It's not a abscess. Why not?
Yeah.
It's possible to
see abscess. The only thing is I was thinking if that was the extent of the infection.
But Fabio, in the abscess there is not infiltrative growth. If you see the cut section on the left, there is the infiltration, also the epicardial layer. There is the infiltration, of course, the cavity.
Yeah.
That's a real infiltration. It's not a simple abscess that growing compress the portion around. To understand me, that's a real infiltrative process, and usually is not a typical presentation of lymphoma, for example, because lymphoma usually is whitish, homogeneous, maybe with some reddish discoloration, but it's reddish. It's whitish homogeneous lymphoma, and is not a typical presentation of chemodectoma, because also for chemodectoma there are not so many reddish discoloration. Okay, Fabio?
Yeah, perfect. Thank you.
Other question?
Yes, Massimiliano. I think was easy, this one, in terms of identifying the mass, and then obviously realizing that the mass is obliterating the right atrial cavity and eventually going to the right ventricle as well. But how the description, because obviously in the exam we get points from the description, I think mostly, and in this case I was trying to describe the mass itself, and I said it was obviously a solid mass with a heterogeneous appearance, with some discoloration in some areas of the mass, but
okay,
externally.
Sorry, Joao. Do you want to read your description?
Yes.
If you want.
Yes. So basically, that's what I was saying. So I wrote a really large solid mass obliterating the right atrial cavity, protruding into the atrioventricular junction with a multifocal reddish or brownish discolored areas that could be an hemorrhagic foci or a necrotic foci, but I struggled to understand whether this mass was capsulated or not, because from the external, from the view on the left, it looks that there is a region that the capsule of the mass has ruptured. So I'm not sure if we need to describe as well that is a large with a smooth surface, multilobulated mass. Is it okay to say like that?
Okay. The growth, you have to put also involvement the external portion of the heart. It could be a good information to write, the external portion of the right. Here we don't see very well the link with the pericardial sac. Is not evident, but of course it's inside. Obviously, is inside the pericardial sac, but here there is not a pericardial sac, and so for the growth, it's not possible to say with capsule because there is not a capsule here. There is also an infiltration, and so if there is infiltration, the capsule is.
So I didn't write anything about the capsule, to be honest, because I was not sure. But on the image on the left, on the tip of the mass, it looks that there is not so smooth there. It looks more irregular, and the rest of the mass looks quite smooth surface. I was wondering whether there was a capsule there that is ruptured, but I was not sure.
Yeah. I agree with you. The external surface is smooth, but from the external surface, but also from the cut section, we may to say that it is multinodular. Multinodular. It could be also a good keyword.
Okay, thank you.
Other question?
Only a quick one. The red, maybe you mentioned it and I missed it. Sorry, but the red spots, right, disseminated in the heart, the red regions that they are central to. Is that just blood?
Yeah, usually that's a good question, Mattia. In the hemangiosarcoma, there is reddish discoloration because histologically the hemangiosarcoma produce something too similar to the origin of the neoplasia. And the origin of the neoplasia are blood vessels. And so neoplasia try to make the same structure. And so if we look at the histological, at the microscope, we see space, irregular space, empty of blood, and these space are formed by endothelial cells, very pleomorphic endothelial cells with a very, very mild stroma. And so they produce hematic lacunae. And that's because it is brownish, because inside there is blood.
Yeah, okay, perfect.
It's like an hematoma.
Yeah.
Also, if you touch a hemangiosarcoma, it's soft, it's not solid like lymphoma or like fibrosarcoma. Because there is inside a lot of blood. And that's because neoplastic cells try to produce the same origin. Of course, pleomorphic, not well differentiated. Any comment?
I guess I gave a description similar to Wow. I just added cavitated to try to describe this blood content with coagulated. So this was my interpretation.
Yeah, coagulated. It's a difficult interpretation. If
because
you say
I guess for me the hemangiosarcoma is a bit cavitated as well, and as you said, is heterogeneous soft, so you've got little cavity with blood in it. So
yeah, but I don't see the cavity in the hemangiosarcoma here.
Well, where you've got the dark discoloration, for me this is a cavitated necrotic with a blood.
No, cavity usually is an empty space. A cavity.
But can be filled with something.
Sure. But in this case, it's filled. The space is not empty. In this picture, there is not empty space. The only empty space is the the space of the cavity of the right and the left heart, but not inside the tumor. The tumor is more or less compact, not very firm, not very solid if you touch, but there are not cysts, there are not cavity inside the tumor. Okay, Jonathan?
Okay, yeah.
Okay, the next one, Alessia, thank you. Another neoplasia. Describe the lesion. Also in this case, we have to say that in the dorsal area, that's a longitudinal cut section of the heart and a huge, big neoplasia that grow from the dorsal portion, from the base of the heart, and tend to infiltrate the surrounding portion of the heart. And this kind of neoplasia is characterized by a main clear, whitish, grayish, compact portion, and very close there is two reddish area, one more reddish, very close between the biggest, the main whitish mass and the left auricle. Did you see? And the other is more inside the neoplasia. And the gross diagnosis is a chemodectoma. Or maybe it could be also better, say, the gross examination, heart-based tumor. Maybe it's more correct. And the question, benign or malignant? Look at the cavity of the right atrium. There is a huge neoplastic thrombus. And so there is a clear infiltrative process, growth of the neoplasia. That's a synthesis. What do you think? Any question? Any problem?
I was actually describing this, I hope quite properly. I wrote heart-based tumor. It looks encapsulated, invading the right atrium. That gives me a malignant appearance, most likely hemodectoma. But I wasn't sure why we have these two absolutely different colors of the same tumor, or we have two tumors. Why one part is whitish and the second part is dark?
Yeah,
this
because
was confusing for me.
yeah, and that's because I put this picture. Also, I'm sorry, because that's more difficult, of course. And the color is because in the chemodectoma, and that's the chemodectoma, but I like also the heart-based tumor. That's also for me correct at the gross examination. There are some portion, and that's the reddish part, in necrotic hemorrhagic situation.
Okay. I was just thinking that maybe just it's misleading and there are two different tumors.
I looked at a case times ago with in the same heart a chemodectoma and a hemangiosarcoma. But the hemangiosarcoma usually is on the right atrium, and the reddish portion is on the left atrium. Did you see, Ursula?
Yes, I see this, and I decided at the end that it is one tumor, just with different appearance, but I wasn't sure.
Okay, sometimes in the cut section of a tumor, we may to see also some colliquative portion. Maybe because inside the tumor, that's because it's malignant, there is a necrosis, colliquative material. Maybe there is hemorrhage. And so it's possible in the cut section of a tumor, in particular if it's malignant, to see some discoloration. What do you think?
Not because of the discoloration, but because of the mass in the right atrium.
Yeah, inside. Nada. Okay, but it's not reddish. It's not inside the right atrium. A typical presentation of
Yeah.
angiosarcoma.
Is there also some degree of right ventricular hypertrophy?
Oh, of
Yeah,
course,
that's what I wanted to say.
of course. That's because there is a okay in the middle between the whitish portion of the neoplasia and the reddish portion, there are two big compressed vessels. Did you see?
Mm-hmm. Yeah, now I saw them, but at first I overlooked them.
Okay, I don't know which vessel they are. I don't know. Maybe aorta, maybe pulmonary artery. I don't know because it's not possible to say. But of course, we need to imagine and also to understand that this kind of mass-induced compression of aorta. And so, if there is a compression of aorta, there is some kind of supravalvular stenosis, for example, or can induce some kind of compression of pulmonary artery. And the same, we have some kind of supravalvular stenosis. You understand?
Yeah.
And so when there is a so big heart-based tumor, there are compression of the atrium and of the vessel. If there is the compression say
What
again?
about the mass in the right atrium? Do you say because is there like I put like invasive? There is a nodule invading the right atrium as well.
Yeah.
Is that what would you say?
Yeah.
So it's just something that is compressing from those.
No, that's the infiltration of the cavity by the tumor.
Okay.
And that's because it's malignant. At the gross examination is malignant.
Yeah.
Because there is the infiltration of the surrounding structure. Fabio, what do you think?
Yeah, I was just questioning the term that I should use because I think before you say there is a thrombus or something like that. But I guess
neoplastic thrombus. Neoplastic thrombus mean that is not a real thrombus with a platelet and such and such.
Yeah.
There is neoplastic thrombus mean that is neoplasia inside a cardiac cavity.
But that implies that the thrombus arrives there, right? With the circulation.
Of course, there is a severe problem in the circulation here, of course. That's incredible how it's possible for a doctor to live. That's great. Yeah. But sometimes we see also a heart-based tumor that is biggest than the heart. That's the nature, incredible. Other question? Everything is clear? For description, for morphological diagnosis? Okay, thank you. Alessia, the next one, thank you. Perfect. What do you think? Which part of the heart?
A longitudinal cut through the left ventricle, and we also see parts of the mitral valve and the left atrium.
Sure, and of course we cut the anterior leaflet of the mitral valve, and just because we want to see better also the outflow tract of the left ventricle, but we see almost all the left atrium, the mitral valve, cutting the anterior leaflet of the mitral valve, and of course we see very well the cavity of the left ventricle, and we cut the left ventricular margin, so the caudal portion of the heart. And of course, it's very, nothing. It's very clear, the finding, because we have a network of whitish strand. That's a very, very florid false tendon. But there is also another problem in this ventricle. and that is the color and also the shape, the thickening of the endocardium. Did you see in the cut section of the left ventricle the whitish line, very, very clear, of the endocardium? And so there are false tendon and diffuse thickening of the left ventricle. It could be for diffuse fibrotic thickening.
Massimiliano?
Yes.
I was wondering because I wrote that it's thick endocardium and everywhere is a whitening, white discoloration and a lot of false tendons and like bridging lesions, fibrotic lesions. I was just wondering, those false tendons are more or less normal, or they are thick as well because of this generalized thickening of the endocardium?
There is a diffuse and also severe thickening of the endocardial layer in the left ventricle. It's very clear.
Mm-hmm. But the false tendons are thick as well or normal?
Say again, Ursula?
The false tendons, are they normal or they are thickened as well?
Sure. They are very thickened, the false tendon. Yeah. They are very florid, too much. That's very, usually we don't see this kind of situation. Sometimes they are very, very smaller than this case.
Mm-hmm.
And a speculation, because I'm not sure that, for example, when we see restrictive cardiomyopathy with the bridge, the connective bridge, we saw also today a case with a bridge of connective tissue between the papillary muscle and the interventricular septum. I don't think that is a new formation, ex novo formation of a connective bridge inside the left ventricle. I suppose that is before a false tendon with some kind of a reaction around the cavity. That's my opinion, but I'm not sure. That's a speculation. Do you understand, Ursula, what I mean?
Mm-hmm. Yeah. I just, if I see false tendons, then I'm most in echo, during echocardiography. And it's, I just subjectively, I would say they are thickened or more thick than they should be. But I was wondering, it's just my subjective opinion, maybe they are normal.
No. In this case, I think it's a very, very severe. Usually we see just a very small false tendon, benign situation. But in this case, there is also a mechanical space inside the cavity. So very strange.
Mm-hmm.
And regarding the diffuse whitish discoloration of the left ventricle in the past, but now we don't listen, we don't read, we don't speak anymore in the cut about fibroelastosis. Do you know? Do you remember? Fibroelastosis they say a malformation because there is a diffuse proliferation of elastic fiber in the left ventricle. Fibroelastosis of fibroelastic component that are increased in the left ventricle. And of course, they can induce a kind of restrictive cardiomyopathy. But now I don't listen, I don't write anymore about fibroelastosis. Of course, fibroelastosis, in the fibroelastosis, there are not false tendons. We see just a diffuse whitish discoloration and the thickening of the endocardial layer. Okay, just for discussion. Any question?
Yes, Massimiliano, can I ask you a question? Because
sure.
In the books, a lot of times we don't see when we do see the description of restricted cardiomyopathy, we do see a lot of the term endomyocardial breach rather than the term false tendons. So in fact, the way I describe it as a cord-like structures resembling severe endocardial bridging. Is that correct?
For me, yes. For me, yes,
Okay.
because I think there is a link. But also for the restrictive cardiomyopathy, so also for endomyocardial fibrosis, is not so common to see the bridge. Sometimes we see the bridge, the connected bridge, but not so frequently.
Yeah.
Maybe
regarding
more.
Regarding the febrile elastosis, I thought about that to be honest as well. But I think the pictures I've seen, usually the endocardium is really, really thick, more thick than in this picture. Is that correct?
Yeah. Usually it is correct. In the fibrinoelastosis, all the endocardium of the left ventricle is uniformly, all the endocardium is whitish and thickening. There are not chorde tendine. There is a proliferation of fibroelastic component of the endocardium. Normally, there is elastic component, elastic fiber in the endocardium, normally. But in this case, there are an increase in fibroelastosis. Okay? Other question?
I do have another question. Can you hear me?
Sure.
But maybe it's just post-mortem, the darkish, reddish decoloration of the apex. Do we have to describe it, or is it for you just post-mortem?
That's post-mortem, because inside there was the blood clot, and in this specific situation is very difficult to remove all the blood clot. We need sometimes we lose some piece of blood clot. That's post-mortem.
Okay. Yes. Thank you.
Also, Massimiliano, I wanted to ask if. So sorry, I understand that it's incorrect then to call these endocardial fibroelastosis, right?
That's correct.
It is correct.
Yeah.
It is good. Okay, because I got it. Okay, perfect.
Yeah, because I remember. Because Mattia, I remember in the past there was many occasion to listen, to speak, to write about fibroelastosis in the left ventricle of the cat. Maybe because we confuse in the past fibroelastosis with endocardial fibrosis in case of I don't know, maybe some cases that we think about fibroelastosis, they were fibrosis, maybe. But now I don't list anymore a lot of information about fibroelastosis. It's very, very rare, this definition. Understand me, Mattia?
Yes. I was just wondering if it would be correct or incorrect to define it as endocardial fibroelastosis.
No, in this case, is not correct. It's a wrong definition. I was just to discuss with you about the color of diffuse color of the ventricle.
Okay. Thank you.
Oh, yeah, welcome. The next one, Alessia, thank you. Oh, wonderful, fantastic. Two different dogs, the same valve, the mitral valve. Describe the abnormality. On the left, so number one, there is a esophytic formation, irregular, yellowish, whitish, and that's a proliferative endocarditis. On the right side, the number two picture, we see in the leaflet diffuse severe thickening of the leaflet with some kind of nodules, with whitish, yellowish also color, and with a normal endocardial surface. So the first is proliferative endocarditis, and the second is myxomatous degeneration. Okay? Sometimes there is a little confusion. What do you think? Do you think it's clear?
Basiliano, this is John. For me, so in this one, I think I agree with the first one. So I said it was the leaflet, the posterior leaflet P2 is irregular. You've got exophytic necrotic lesion, so with rupture of chordae tendineae. So I'm not sure about that. But for the other one, I said I gave the same description with the yellowish color and stuff like that. But I said that vegetative endocarditis cannot be ruled out, and I put mitral valve disease as well as a differential. But do you think is acceptable to put both? Because I'm not sure we can, when it's very advanced, like differentiate with a vegetative endocarditis with mitral valve disease. I mean, in this case, I thought we couldn't, but I don't know what the others think.
Yeah, you say that in general, sometimes it's difficult to recognize proliferative polypoid endocarditis and myxomatous degeneration.
Yes.
Yeah, but take care, because the correct name is myxomatous degeneration. Okay, there are some synonym words, but of course, endocardiosis in general is not correct, is not the right name, also if it's the most common. The most correct name is, from a pathological point of view, myxomatous degeneration. Anyway, in the myxomatous degeneration, the endocardial layer is normal. There are not vegetation. Of course, there are the irregular thickening of the leaflet, something like a nodules. You see on the right picture. And I think if you look carefully, I think it's clear, because in the polypoid endocarditis, there is something of new. There is a new formation. Of course, it's not a neoplasia, but there is something that hard in the surface. Jonathan, what can I say for you to explain better? Because
I understand. So when there is neoformation, you would say polypoid endocarditis.
Yeah, polypoid endocarditis.
But since there is no like a new tissue here, it doesn't seem to be. This yellowish, I thought that there was potentially some sort of, like a bit like cauliflower aspect,
No, it's because there is a fat. It's because there is fat. But also in the myxomatous degeneration, there is a new component. Because if there is a thickening, it's because there is accumulation of something. And this kind of lesion, so in the myxomatous degeneration, there is a new entity, and that's the myxomatous tissue. But where is the myxomatous tissue? Is not in the endocardial layer, is in the middle of the leaflet.